Good evening, everybody. Welcome to this evening's webinar, hosted by ourselves and Topcon Healthcare. So we're delighted to have Nicola Bennett with us today, Topcon Clinical Affairs Manager for UK and Ireland, and she's going to talk us through how to interpret and learn how to interpret OCT. Over to you, Nicola.
Thank you, David. Good evening, everybody, and thank you for joining this evening's webinar. I'm Nicola. As David has just said, I am from Topcon. I am the Clinical Affairs Manager for UK and Ireland. I've been working for Topcon for the past nearly 5 years. A little bit about me. I have come from optometry practice as a receptionist, where I began, and found a massive passion for eye health and eye care, especially in pre-screening. Worked on the worshipful company of spectacle makers, dispensing and practice management courses, but still had an extra passion, if you like, for the OCT and pre-screening side of the obviously healthcare within the optometry sector. Worked with Topcon since 2018, typically training on OCT and how to capture the best images within optometry and ophthalmology. And since studied then a degree in OCT capture and interpretation. That then caused me to be promoted, and I now train on all of Topcon's kit and head up the team across the country, but also have a specialist passion, if you like, for eye health, but specifically in relation to OCT. So thank you for joining. Hopefully you'll find this evening's webinar helpful. If you do have any questions, then please do put them into the chat, and David will help to keep an eye on that for me. So I start off with a fundus photo. Now, the reason why I start off with a fundus photo is because one of the key things about yourselves and any clinician that's starting to look and learn how to interpret OCT is the factors of what you've been looking at before. So when you're looking at a fundus photo, we're able to get information which we would look at alongside the patient's records, the patient's clinical information, any medication they're taking, any kind of family health histories that we need to know about, as well as the other eye care services that we can do within the practice. Now, when we're looking at this fundus, we're able to get information. We can look at the vessels, we can look at the optic disc and the macula, but we're only seeing the sort of surface, aren't we? So what we're going to do when we start to look at OCT is peel back those layers and take that deeper look of what we're going to be learning to visualize and interpret with our patients. Now, it may be that we see even more information that we can already see on the fundus, just in more enhanced depth. So it's really important that we still remember as clinicians that we have a lot that we're building into our storyboard when we start to learn and interpret OCT. In all of the interpretation exams I've ever sat, I've always had more than one B scan or one image to look at. I've pulled all of that information together. Now, what's important is to start to get an idea of what normal looks like. So if we're thinking about OCT and we're starting to look at our B scan image, how do we know what normal looks like? Now, there's many different variations of normal, as we know, on the majority of everything that we have with our patients. But when we're looking at an OCT and our B scan cross-sectional image, we know that our retinal nerve fibre layer tends to be thickest nasally and then thinnest temporally. We may see vitreous formations, which we'll go on to in more depth in a moment. We can visualise our posterior hyaloid layer, and we can see that quite clearly now on some of our patients, not on everybody, but on some of them quite clearly. We can visualise the inner limiting membrane, and an inner limiting membrane, we should have that smooth and even. We have this normal foveal depression, sometimes shallower, sometimes deeper on other patients, but we should have this foveal depression. We can then see that the retinal profile has highly and hyporeflective layers that starts to help us build our interpretation of OCT. It's important to understand there's different types of OCT on the market. So spectral domain OCT, where we're looking at a spectral domain OCT, we're looking at a laser length of 840 nanometers. There's swept source OCT, which has a laser length of 1050 nanometers. So with that extra laser length, we may penetrate that little bit further, that little bit deeper, and therefore you may see some images where you get retina, choroid and vitreous all in one image. This image, as you can see here, we've got our vitreous, we do have our retinal B scan slice, and we then can see our choroidal structure in quite some depth. If we're starting to talk about our layers, then looking at OCT not just as a cross-section, but also as a 3D image can help us to start to understand and visualize those. And we're going to look at the layers in a few different ways in a moment. But if we're looking at this 3D image here, you can see where we've got the red, and you can then see the highly and hyporeflective sections as well. So we have our inner limiting membrane. We then have our retinal nerve fiber layer. We have our ganglion cell layer, inner plexiform layer, and inner nuclear layer. So we're talking about our inner retinal section. You may hear also of the retinal and ganglion cell complex, where you're going from retinal nerve fiber layer, ganglion cell, inner plexiform, and inner nuclear layer. The ganglion cell is spoken about more and more these days in relation to earlier changes, and we can help visualize that through our B-scan images. We then come down and we have our outer plexiform layer, our outer nuclear layer, the external limiting membrane, which is very thin, but still highly reflective. Okay, and that sits above our photoreceptors. So we've got our inner sector and our outer sector of photoreceptors, the RPE and Brooks. So when we're looking at this structure, we can start to visualize and learn those layers. Now, if we look at them on a sort of more enhanced image, we start to see that there's actually 19 layers of the retina. Now, do we need to know them off the top of our heads and off by heart? Maybe not, but it's good to understand where the sections sit and how these can then be affected, and what pathology we may find or what changes we may find within these sections. So when we're looking here and we're starting to understand how big our retinal structure is, normally we're looking about 0.5, 0.6 millimeters thick for our retinal complex. Now, from the intraretinal section, we can run from the ILM down to the ELM. So again, do you remember I've said it's a highly reflective, but not as highly reflective as the photoreceptor. So this is our external limiting membrane here. We go from our intraretinal section to our external limiting membrane, and that's the greater segment of the retina that you're looking at in that point. We then go to our subretinal section, and that's underneath the sort of photoreceptors and the ELM, but still above the RPE. We then come down underneath the RPE, and you're looking at a sub-RPE section. So typically, that's more about your choroidal circulation, but remembering that you have the RPE and Brooks membrane. So we're wanting to be aware we've got those three sections, but being able to look at all three of those sections individually and starting to build up our interpretation for each of those sections. Now, when your patient comes in, what we want to make sure is, obviously we've said about what normal looks like, but we want to be aware of the areas that will start to affect the vision. Now, if we're looking at our external limiting membrane, our photoreceptors, so our myoid zone or our lipid zone as they may be known, outer segment of photoreceptors and indigitation zone, these are the areas where you may start to find your patient does have some visual symptoms or changes. They could have changes, however, in the intraretinal section or the vitreous, and they may not have any visual change. So it's really important that when we're talking to our patients, that we still find that information out, which you would do on your normal everyday communications with those patients. You can see here also we have Sattler's and Haller's layer and the choroidal scleral junction. So this is because we're able to visualize the choroidal structure a lot clearer on this image. Now, when I was taught interpretation, it was really beneficial for me to kind of have a process to how I wanted to learn and start to look at a B-scan image. And I kept this in my mind as I was starting to learn and look at these images to help me ensure I didn't miss anything, but also to help me understand what I was looking for and where things may be changing. So looking at scan quality, overall scan profile and foveal appearance, assessments, but of vitreous, epiretinal, intraretinal, sub and sub-RPE sections helps us to sort of understand and appreciate what we are looking at. Now, you could do it the other way. You can go from sub-RP up to vitreous. That's completely up to you. Everybody learns differently, and there is no right or wrong. It's just making sure you are checking each of those images. Now, if we think about scan quality, why would we be looking at it? What is it that's important about the scan quality that's going to have any impact on my interpretation? Well, if I've got a grainy scan, then how can I interpret that image properly? Because if it's grainy, one, I need to know why it's grainy. Secondly, I want to know and see if I can clearly identify inner and outer layers so I can start to look at the structure. And if I can't, then there could be missing data and I might be not seeing the full story for that patient. So reasons, first of all, for why we have poor scan quality: lens opacities, obviously pathology, but dry eye has been significantly proven to basically encourage and decrease the fact of our scan quality. So trying to maybe use lubrication drops that can help increase our scan quality. Making sure your patient has a refreshed tear film, so being able to blink before a scan is captured. Making sure a patient is positioned properly. These basics actually are something that's quite often forgotten, but it has such an impact on how an image is interpreted when it comes through to you as the clinicians. So trying to ensure good scan quality, and depending on the device you're using, there's normally a registered score, something that's recommended as a good scan quality. If you can obviously try and recapture a scan, if there's missing information, that's really important, because a patient will blink. We know that our patients are going to blink. And what we want to do is try and make sure that that information where they've blinked isn't missing. So to recapture the image is going to be beneficial. Sometimes a scan might be taken too high or too low, and you can play and with that on capture as well. Normally you can change the Z-lock bar on the majority of the machines and bring the image down or higher. We want to knock out the noise on a scan. And also we want to be aware of the patients that are trickier. Maybe our myopic eyes, they may be harder to image. So all of these things we're looking for. But what about shadows? Shadows typically can come if there's obviously pathology again, but what about artifactual shadows? So what about the vitreous? Being able to see floaters, they can obviously then block out the signal, and therefore that means we might not see that part of the retina as well. So asking a patient to blink, to look up, look down, to try and see if we can move those floaters does have a benefit. So all these things just to try and help us get the best possible scan quality. Now, this is just some examples. So if you're looking at scan quality, here you can see in this top left image, we have a poor scan quality due to media opacities. The image where you've got the vertical line coming through it, the purple vertical line, you can see that we've got a shadow. Now that shadow is due to artifact, and that's from a vitreous floater. So that overcast and vitreous floater is causing the shadow, and that's meaning that we can't really clearly interpret that part of the scan. The bottom image, those of you that may have seen scans before or maybe using an optic disc scan, this does look a little bit like it could be the physiological cup, but actually it's not. It's missing data. So this section here hasn't got any data. So we're not seeing that bit of information about that patient. So we would want to encourage that scan to be recaptured. We have to be very mindful of artifacts, and we'll come on to that as we can continue through the session. Now, obviously some artifacts you'll get, and that's just because they are normal. And this is an example of that. So we have some shadows, which are our blood vessels. And as I scroll through the scan, you can see them quite clearly. And that's something that we get asked quite often by people who start using their OCTs, but these are normal shadows that we are aware of from our vessels. Lots of the OCT companies out there also do something called pinpoint recognition, where you're able to pinpoint a point on the fundus and takes that point to the B scan or vice versa. So don't forget, the majority of them have the fundus photo and the B scan together, And that helps you to start to understand and start to learn how you might have seen something visually on a fundus photo, and then how you visualize that and interpret that on your OCT scan. Now, scan profile. So when we talked earlier about normal, again, what's your scan profile like? Is it looking normal? So we said, or I said to you, that a normal looking scan profile would have a thicker retinal nerve fiber layer nasally and thinnest temporally, smooth inner limiting membrane, and a normal foveal depression. We'd then have the hyper and hyporeflective layers. Now, also important to point out, sometimes you may be visualizing OCTs in color. Typically these days they tend to be in black and white, but you may even get them in reverse, depending on the OCT device you're using and depending on how the clinic is interpreting and using that software. So in this top box, we can see we do have a normal profile. We can see our posterior hyaloid layer and we can see a vitreous structure, but we can see that we've got a normal profile for that patient. In this middle image, we've got a much thickened sort of profile that we can visualize. And we've got this kind of crinkling on our top of our inner retinal section. We've lost our normal foveal depression. So therefore, this thickened retinal image is due to this ERM that's at the top. Now you can see that that's holding on at these inner retinal sort of multifocal points and is starting to change the profile of the retina. Now, again, the external limiting membrane, our photoreceptors and our RPE are intact, so the patient's vision may not yet be disrupted. There may be a little bit of disruption down here, but their vision may still be okay. Now, this bottom image is actually interesting, and we use this because it's actually when we're starting to learn about our patient. Now, some of the patients you may have seen many times before. Other patients may be new and they don't always know necessarily what's happened to them previously if they've been to ophthalmology or they've had surgeries done. So sometimes you'll see an image that looks abnormal for you because the scan profile or the layers look different, but it may be normal for that patient. And this is an example of that because our scan profile has changed and it's kind of got this crinkling effect. And in our inner retinal section, we have got some sort of cystic spaces. And we've got a little bit of sort of bubbling, if you like, in the RPE, and it changes to that section. And this is because this patient is after surgery, after an inner limiting membrane peel or an epiretinal membrane peel. So from that, it means they've come back and this is how they are left. So this for this patient now is normal. So looking at scan profiles, but again, talking to your patient and getting as much information out of them as possible. Now, if we're talking about the vitreous, and the reason why we talk about the vitreous now is because as OCTs have kind of progressed, the same as all technology is these days, it means that we're able to visualize the vitreous structures a lot more clearer. We pick up the different densities that are available. So on this top image, we can see we've got our visualization of our posterior hyaloid layer, but it's all nicely intact. The retinal profile is normal and we can just visualize that. And there's no changes to that patient's B scan. Okay, we can't see anything else in the vitreous up here, but what we can see is our normal retinal profile. Important also, just while I've got this image, is sometimes here, you'll see that there's this little lip on some patients. Now that can also be where the cones sit that little bit more prominent in that section of the kind of very detailed vision. So you may see that as a normal structure on some patients, but not on others. So just important to point that out while I've got to visualize it of it. Now back to our vitreous. So here we can see the posterior hyaloid layer on this sort of colored image. And we can see some sort of other bits of vitreous sort of floating around. However, our profile looks as if it's fairly okay. So we've got our normal sort of foveal depression. We do have these little cystic spaces either side, but the photoreceptors, the LM and the RPE are all intact. So again, the patient's vision is probably okay. Now, what could have happened is that this posterior hyaloid layer at some point was pulling and causing traction to the retinal profile, and that has come away and that's now started to settle on its own. It may be also that we have to remember that not only is the vitreous hyaloid layer attached at the macula, but also at the disc. So using OCT, and a lot of the OCTs out there have these wider scans now that we can capture, or we're able to take a separate image of the disc and the macula to be able to ensure we're looking at that still and monitoring that, even when it's come away from that macular profile. This bottom image we have, where you can see we've got vitreomacular traction written, we've got our posterior hyaloid layer, which is very clear to see. And can you see the retinal profile has now changed? So our normal foveal depression has disappeared, and we've got this thickened retinal profile. So again, our ELM, our photoreceptors and RPE are still intact, but we don't have our normal foveal depression because it's started to cause that bit of traction. We do, as I say, pick up different densities in the vitreous now, and there are some normal vitreous formations. Now, we don't see these on everybody, but it's important that when we do know that they are there and we do visualize them, that they are normal parts of the vitreous. So this one here, which I like to think of a whale's tail, is our premacular bursa. We also have Martichiana at Cloquet's canal, which sits more around the disc. So again, on some systems, you'll be able to enhance the vitreous visualization. And when you do that, it may change the contrast of the B scan, but it brings out the vitreous visualization a lot more. So either to see those normal formations, or also just to start to look at the posterior hyaloid layer, seeing if there's any traction, seeing if there's any changing or pulling to that retinal B scan slice. Now, if we're looking at our sort of inner limiting membrane, that very top surface, we're really looking to assess the epiretinal sections. So if we're looking at the epiretinal section, here we can see that we do have this kind of sparkling, don't we? And we know that an epiretinal membrane is an abnormal guard proliferation. It sits on the top surface of the retina. When you look through, you see a shimmering, a sparkle. That's really no different to what we and how we visualize it on our retinal B scan profile. When we're looking at it, we can see sometimes you'll just see a little sparkle like this. Other times you'll see it sort of holding on at the inner sort of retinal focal points. I like to think of these little teeth that it's holding on to. And here we can see that we haven't really got much change to our retinal profile, a little bit thicker, but again, still just about got our normal foveal depression. No changes really in the interretinal section, no sign of any sort of subretinal fluid or anything changing in the subretina. And our photoreceptors, our ELM and our RPE are all still intact. On this bottom image where you can see the red arrows, you can see that we've got a much thickened retinal profile. Again, we've got this sort of sparkling, shimmering epiretinal surface that we can see, and it has thickened and changed that profile. But looking at our ELM, our photoreceptors and RPE, they're all intact. So again, this patient's vision may still be okay. So again, you're pulling in that extra bit of information and you're starting to see how you would look after this patient and what would you do with that patient moving forward. If we think about the intraretinal section, again, I said it's the largest segment of the retina, we want to be aware of the changes that we can see in that intraretinal section. So from the internal limiting membrane at the very top, as we've spoken about, down to the ELM, which is this very sort of highly reflective and very thin layer, but very important that we note it and we watch any changes. So from ILM to ELM, our intraretinal section. What typically would we see in this section? We might see cystic spaces. We might see a hooded microaneurysm where you've got that sort of darker circle and the highly reflective area around the ring around the edge. You might see an exudate, which is more typically looking like this, more of a blobby shape, if you like, or a blobular shape. You may see highly reflective foci. You may see intraretinal cystic spaces or intraretinal fluid. You might see cystoid macular edema. You might see obviously some thickening or some thinning of the retinal layers. You know, we get a lot of vascular changes that sit in our intraretinal section. So obviously being able to understand what you're looking at, but also remembering that a lot of those can be quite superficial. So you may see those on your fundus photos. So if you've got a patient, for instance, who's got a vein occlusion, you'd see obviously the image on the fundus photo. You should then see a large amount of sort of swelling and edema in that section. as well. So you'll be able to build up and start to look at that patient and the story that's happening with them. Down here in this bottom image, you can see we've got some very localized and very sort of non-reflective, well-defined cysts. And this is typical of cystoid macular edema. Now, important because this patient was a patient who has had a cataract, and they've come back into us, and this is what we've visualized. Now, you can see the profile has changed, hasn't it? So we haven't got our normal foveal depression. But if we look from our ILM, our ELM is still intact, our photoreceptors and our RP. So we do know that it's only in the intraretinal section. You get a lot of differential diagnosis with OCT. So again, how do we know the difference between macular edema, diabetic macular edema? We're starting to pull everything together, aren't we? We're going to start to see what else is happening with that patient to help us come to our diagnosis for that patient. Now, again, looking at the intraretinal section, on this image, we have got some changes in the intraretinal section, but we've got some changes in our sub and our sub-RPE sections as well. So this is a bit more typical of a sort of a new membrane, and having those kind of changes, being able to visualize not just in one section, which this is our intraretinal section we're looking at here, and then trying to work out where the boundaries are. So when there's change in more than one section, we can see when we start to lose the LM or the photoreceptors and start to piece that together. So always go back to a point that's intact, and then either use your mouse or your finger to start to build along and see where those changes have happened. So with this patient, we're looking at a cystoid, and we've got obviously the CMO, we've got a PD, and we've also got the CMV, which we can see as this highly reflective mass in the center here. Now, we spoke earlier about the subretinal section, and obviously then we go on to the sub-RPE. Typically, when you're looking at the subretinal section, you're going to be looking for fluid. You might get subreticular drusen, and you may be able to see those and visualize those quite clearly, but typically you're looking for that area of sort of subretinal fluid that may happen, especially something quite common that we see on our OCTs is our patients with CSR. Now, CSR can obviously be fairly simple. We know that we have many patients who come into us with CSR, but again, using OCT to understand and be able to visualize that and also educate the patient and move that patient on to where they need to go if necessary, but understanding that that CSR can sometimes become chronic CSR and become a bit more complex. So we're starting to see and visualize this section and understand what's happening for that patient. Typically on the fundus photo, we'd have seen it as a blister-like appearance. So again, that resembles then and pinpointing between the two. You may have on some of your OCTs something called a shadogram that overlays surface images of the scan on top of the retinal, on the fundus photo, sorry. Now, if you do, that can sometimes help you to visualize the structure, if you like, of the vessels, but also areas of fluid, drusens, areas of change, maybe floaters, and also doing a quality control check, looking for those small micro movements or those larger big blink artifacts. If you're interpreting an OCT scan and you've not captured it, it's really important to do quality control checks yourself to make sure that you're looking out for those artifacts and changes with those patients. Now, if we look at our subretinal and our sub-RPE, as I've said, typically, what are we going to see in the RPE? We know we get age-related changes. Unfortunately, it comes to us all. We want to be able to talk to our patient about the modifiable risks. We want to be able to educate them. We want to be able to help them as much as possible. But also, we want to be able to monitor them and use our OCTs to be able to do that. And the way we can do that is by being able to take a scan and being able to look at that patient over time. And that's really important that we remember that to help build up the education for that patient and the care, and obviously being able to monitor them and also then refer them in if need be. So here, when you're looking at the drusens, we've got the little kind of typical drusens that you can see here, but there's many different types of drusens that we visualize. So obviously we've said about subreticular drusens, we have drusenoid PEDs, we have soft, we have hard, we have confluent, and actually it's about the material that sits within the drusen that we're really sort of watching and being able to monitor and see that change over time. Now, unfortunately, we do still have a lot of patients that we would see that would have dry AMD. And at this moment in time, obviously, as we know, we're sort of really haven't got much that we can be doing with them other than sort of looking after them, taking their OCTs and obviously educating where we can. Now, with this patient, you can see we've got an extremely thinned RPE. Okay, so we've got this large area of atrophy. Now, when you see a patient who's got a thinned RPE, again, you'll get an artifact. And this artifact here, you can see sort of this waterfall artifact, also known as a window defect, is because how OCT works is the light hits the RPE and then it bounces back. Now, if the signal penetrates through because the RPE is so thinned, that's when we get this kind of waterfall or window defect, because the over penetration of the signal. So it's really important that we understand with our patients where the RPE is thinning, this is a typical artifact we may see. Now, this scan is something called a line scan. So most of the OCTs out there, especially if we're taking a pre-screen image or we're taking an image to get as much information as possible, we would use cube scans. Cube scans tend to be sequential cube sort of scan slices, slice after slice. When we're using enhanced scans, so either maybe you heard of a single line or a raster or a 5-line cross, a radial, they're more enhanced scans, but they are used as extras. They're not our sort of general cube pre-screening scans. So it's really important also to understand the scan protocols that you're having or you may be interpreting from in the practice or in that clinic. Now, when you are interpreting OCT, obviously we've just gone through the kind of skills that we would use, looking at profile, looking at scan quality, being able to assess all of those sections. But on all of the companies out there, you probably would have some analysis tools that would help you. Now, what I would strongly say is that for each company's device, these tools may be slightly different. So it's important that you get the hang or you understand the numbers and the kind of the color codings of those companies' scans that you're interpreting. So here we're looking at sort of temperature thickness maps that give us an indication of how thick our retinal image may be. And then at the bottom, we're looking at the ETDRS grid. So if I just talk through these temperature thickness maps for the companies that these belong to, we've got this green and yellow kind of donut, if you like. I like to think of the macular area as a donut with a normal foveal depression. We tend to see sort of a cooler colour in the centre and that dip. This is green and yellow, which for this kind of thickness map is within the norm. When we see pitted, that tends to be more drusenoid, okay, and drusens that we're visualizing. When we see this angrier structure, so more volcanic and more kind of angry looking, we tend to see that we've got a thicker than normal retinal profile. So reds and whites is taking us into that angry and sort of thicker than normal retinal profile. Now, you may have seen the ETDRS grid or certainly heard of the ETDRS grid before. Now, early treatment diabetic retinopathy study tool. Now, what this does is it gives us an indication of how thick or how thin or how normal our retinal profile is. Now, with any of the companies out there, you're using a normative data comparison to compare that patient to for the first couple of times that they come in, because this is your baseline scan. So this is all you have to compare them with. Now, obviously be aware that not everyone fits into a normative database. So what we have to be aware of is, yes, 90% of the population may be in the green, and that's good. We can see on the retinal profile and we've got all of the rest of the clinical history, so we know that that patient is normal. If you're seeing sort of pinks or purples, then you're in the top 1% of outside normal limits on this ETDRS grid for this company. That's saying that you're thicker than the norm. But if you're in the yellow, you're in the bottom 5% of being outside normal limits for being thinner than the norm. So we've got a bit of thinning and we've got a bit of thickening. So this is probably relating to this patient up here where we've got a bit of atrophy maybe, and we might have some thickening because it's a retinal image of a wet AMD patient. This here, where we've got the reds in the kind of central sort of 3mm circle, we're saying that we're thinner than normal in that section. That's typically probably relating to a patient who's thinned, or maybe they've got a myopic eye, so therefore they're stretched anyway, so they may come out thinner than normal. Now, if I'm scanned, I actually come out all pink. So I'm in the top 1% of being outside normal limits, However, my retinal profile is normal. So you as a clinician would have taken my pressures, my visual fields, you'd have looked and obviously got my eye health history. And that would mean that you would understand that that's me being compared to somebody and I am, for some reason, thicker than the norm in comparison to the person I'm being compared with. And it would be your clinical judgment from everything else pulled in that helps you make that decision. So yes, these are important to have and understand, but they're used alongside everything else when we're looking at our OCT. Now, when we're looking at optic discs, in all honesty, the majority of optic nerve head information and optic disc analysis is still very much down to how you visualize that when you're looking through, when you're looking at a fundus. You've been doing that for many years. You can look at a fundus image, you can look at the optic disc, you can look through the ophthalmoscope, and you know that that disc doesn't look quite right. You know, you make your cut to disc ratios, you take those measurements, and you know where that patient is sitting. With this, with OCT, how it's changed and really brought to life OCT is by being able to monitor that patient and look at that change over time using progression and trend analysis and comparisons. Now, this topography varies again from the points that it's taken from, depending on the company's OCTs that you're using. So when you're looking here, we're looking at the blue of the rim and the pink of the cup. And again, on our tomogram, we've got the pink of the cup and the blue of the rim and green of Brooks membrane. And we can see the physiological B-scan slice. So the measurements that we take are actually different to what you would see yourself because we're taking it from a different point that you can't see with the human eye. So therefore, we write down our own measurements, but we still use the ones on our OCT for repeatability, reliability, as we have a good scan capture to be able to look after that patient moving forward. If we see thickening of our optic nerve, again, we know we don't grow retinal nerve fibre layer. So we've got to be very aware of what's going on with that patient. Again, the histories, is there anything abnormal that you're concerned about when you're looking at the physiological sort of image of that fundus photo with the disc? Is there anything sort of pulling out on the infrared or the red-free image? All of those really help you to build up the analysis. Again, you will get thickening and thinning ideas from looking at the circle sector wheels. And again, you get temperature thickness maps in relation to retinal nerve fibre layer. I always think of the retinal nerve fibre layer as a butterfly. You know, we know the superior and the inferior bundles are thickest, and we know that we kind of have these wings that splay out. And actually being able to visualize the retinal nerve fibre layer en face, which means we're looking at a structure from above, is really quite nice for us to understand how that retinal nerve fibre layer and ganglion cell sectors all lead around into that very fine and delicate area that we call our vulnerability zone. Now, you'll probably see grids and graphs that help you to understand how thin or thick your patient is in comparison to a norm. Now, this is a circumpillary retinal nerve fibre layer graph, and we've got the temporal section in the centre. So we've had a circle sector, if you like, that's been captured around, split at the nasal point, and that's where we kind of looking at the analysis for this patient as a black line being the patient. Now, we know we're going to have peaks. We know that will happen because of where obviously the vessels are sitting, and we know that sometimes those peaks on a myo may be closer together, so that can sometimes push our black line into the red. So we've got to be very aware that this patient is being compared, as I said, to the normative database, and how does that patient then compare on the second or third or fourth visit? So you've got to pull in the information to try and help understand, but typically we would have other bits of information to help understand and use for referrals on our patients. Also be aware of artifacts on these interpretation and analysis tools. If you have a blink and there's a section missing in the B scan or over the area of the physiological cup, remember that that could cause the black line to come into the red. And that could be because it's thinking it's thinned, but it's not. It's a section where there is no data. So just be very mindful looking at the artifacts. We get lots and lots of artifacts, especially around the disc, because when the disc is being captured, they're looking slightly nasal. So sometimes they find that harder to fixate. Sometimes we can move the internal fixation to get a better scan image. So really remember all these tips just to help create the best possible images for you. Now, this is just an indication of what some softwares can look like. You tend to have a fundus photo, you tend to have red frieze. This is an unfolded version of the circle that you're looking at here, and we can visualize the segmentation of the retinal nerve fibre layer, which is highly reflective. We can see where we've got this area thinning, that we do have our black line dip, and we can see that we've got this dense data, and again, the kind of butterfly that I've said, where you've got this typical wedge defect. So just being able to visualize that and look at them in different ways helps you to understand what's going on. So very much red free is good for visualizing retinal nerve fibre layer also. Again, lots of information comes from reports. So if you're looking at a patient, you can generate a report. Typically, when we're looking at discs, we want to look for the symmetry, don't we? We want to see how symmetrical they are. That could mean if they're more asymmetrical, that they're more glaucomatous, not necessarily, because it very much depends on our patients. But also just starting to think, if you've got any abnormal thickening, what's going on with that patient? Where are you seeing all this information? So depending again on the machines you're using, find out what reports are available. If there's just a single report, is it possible to do an OU report and visualize those together? Now, ganglion cell, now on the wide scans that tend to happen now across the board, you tend to find you can get retinal nerve, fibre layer, retina and ganglion cell analysis in one scan. Now, that's great because it gives us a lot of information. We're starting to look at changes in ganglion cell in relation to macular field defects and retinal nerve fibre layer. But actually what is important is sometimes you'll get a patient that's thrown off of the analysis, and that can be because they have maybe a myopic eye, maybe a tilted disc, maybe atrophy around the disc, and that is harder then for us to be able to interpret. So taking a macular vertical scan as an extra, and I always say as an extra because you're only looking at 50% of retinal nerve fibre layer if you're taking a macular scan. So what you have to be aware of is that you would take your normal pre-screening scans, and this would be an extra. It helps you then to look at the thickness maps of the ganglion cell and look at the symmetry between those two. You can then use this to look at structure and function using a macular field visual field test. So really, just before I show you a couple of cases, we need to learn our retinal layers, but not to the detriment that you're bogging yourself down, but to probably the fact that you understand where the sections sit. So the intraretinal, the sub and the sub-RPE sections, that helps you to be able to talk through that with your colleagues, to be able to do it with your referrals, and also for you to have the understanding of where you may find the different pathologies in those sections. Being methodical, so analysing the scans step by step, again, really important. So it feels like it's a lot of information when you first start using OCT. And actually what tends to happen is you forget, or you feel like you lose your confidence as a clinician because you feel like it's taken away with the OCT. What's best is for you to remember that you know, as clinicians, you've been looking after patients for many years without OCT, that actually that extra bit of story, that extra bit of information is how you're going to look after and monitor and especially educate those patients. That's a big thing these days, is educating and communicating with them. So don't forget, before you had OCT, patients' history, symptoms, visions, fundus images, refraction, all help build interpretation. If it baffles you and you've got an OCT image that you're interpreting, take it out, think about what you would have done before, and then pull it back in. That helps you then to remember how you used to look after that patient. What's this extra information telling you, and how does that differ from what you would have done before? Familiarizing yourself, but not just actually with macular conditions, but also conditions around the disc, about the vitreous, making sure that you can understand and have a good idea about what's going on with those patients. Okay, so I've just got a couple of cases just to go through. I think I'm still doing okay for time. So these will just help you really just to have a little bit of an indication. They're nothing too much, but it just means that they're things that you may start to see in your kind of interpretation when you're in clinics or when you're sort of starting to get this information come in for your patients. Now, this case, obviously you can see all the information here in front of you, but it's a 65-year-old female. General health is good, taking some medications, but not reporting any sort of allergies or anything of any sort of ocular health. So occasional smoker, reports no change since last test, and notice an eye or closing the eye when reading. So with this, I'm just going to talk them through. If you want to, you can put in the chat what you think you might be looking at, just so we can have an indication of what you're feeling as we go through. But typically, when we're looking at this, we've got a 65-year-old, vision is now 6/9, reports no change since the last test, and notice they're closing their eye when reading. So when we're looking at this B scan, obviously now what's different is we're going to start to see that maybe different contrast, different images that we're looking at. Also important to note, when you're looking at your B scan images, obviously I said about your scan quality. Scan quality will always normally be on a B scan, but also so will your scan slice number. So just making sure you understand which one's a scan slice number and which one is the image quality. On this image, this is a scan slice number. So we're looking at scan slice 62. So we would scroll through, which is really important. Always scrolling through from left to right on any of your OCT images is massively important. Now, when you're looking at here, what can we see and where can we see our changes? So with this patient, we can see that we have a smooth sort of inner limited membrane, maybe a little bit of sparkle, so typical, maybe an early kind of ERM happening, normal foveal depression, intraretinal section is okay. We've then got our external limited membrane, which we can see and actually is fairly intact. We do have a little bit of change here, which looks like a little bit of pigment migration. So we do have in the RPE these sort of softer changes, don't we, in these drusens that you can probably see here. So I'm sure you've all looked, I can't see on my phone, but you have got a drusen for this patient. So maybe some changes in relation to AMD, and we can start to see the pigment that's migrating off from the RPE into the retina. You don't tend to find this goes past the external limited membrane, so you don't tend to find it in the internal limit in the intraretinal section sometimes. But it's important to note, and obviously being aware of this patient. Obviously, we know that they were an occasional smoker, so you could use this B scan to educate that patient. So case number 2, you've got a patient who is 85, male, prescription as per the screen. We can also see now that we have a general health is good, no medications, family history of mother having glaucoma, and obviously patients sort of not really sure, and that happens a lot, doesn't it? We get a lot of patients who are starting to not really know about what's happened to them beforehand. They've noticed that they've got gradual reduction in their vision over the past 15 years, but this is important. There's been no change since the last check a year ago. Okay, and it's good to see you are all joining in on the chat, so thank you. Amsler grid was given, but only used when remembers. So 85-year-old, 6/18, noticed a gradual reduction in the vision, past 15 years, so no change since the last 12-month check. So again, with this one, what are we looking at? What's the thought? So again, remembering when you're starting to look at this image, what's happening? Can we see our vitreous? What's happening with our scan profile? Which sections are we starting to see the change? Now, sadly for this patient, this is going to be about educating them, isn't it? Again, as you've all put, you're all starting to shout out what it is, which is great. We can see that our inner limited membrane is smooth. We do have a normal foveal depression. Our intraretinal section, so again, remember from ILM to ELM, we can physically see is still intact. We can't see any sort of change of fluid, so we know that there isn't sort of any sub-RPE fluids. We can see that actually either side of our macular area, everything pretty much is okay, but we do have these little rumbles, don't we, in the RPE, and then extremely thinned RPE in this central section. Now here, can you see that you've got this shadow? That's typical of like this bit of pigment that we can see here. So again, we can see that pigment that's sort of coming off the RPE, and we've got this window defect, which quite rightly so, you've all written, this is a patient who has dry AMD and geographic atrophy. So well done, that's very good. So our third patient, we have a 57-year-old female. And again, general health, diabetes, type 2, 5 years, diets controlled, and last screening was 7 months ago, and was told actually all was okay. Non-smoker, no family ocular health, and using Hikison drops as and when. So reports no problems. Past 4 weeks though, occasionally in the right eye, it's not quite as good, but still okay. So vision's still okay, but not maybe as good as it was previously. So 57, the patient has a VA of a 7.5 and the vision is still okay. So what's your thoughts here? So we can look again at our image. We haven't got the scan quality, but the scan is fairly good. We can see the retinal section, so we can interpret this scan. We've got our posterior hyaloid layer that we can visualize, okay, and we can see that quite nicely here. Our main sort of point that we've seen the change, can you see you've got this kind of hyperreflective, which little spot, which is our umber reflex, but we've got the interretinal cystic space that we are visualizing here. So we've got a cystic change, but actually our intraretinal section, other than that, either side is okay. The ELM, the photoreceptors and the RP are intact. However, we do have this sort of little bit of change, don't we? So maybe that's what's causing the slight drop in vision. But quite rightly so, you've all sort of said that this is a VMT. Sometimes people say it's a VMA, so you can get vitreous macular adhesion and vitreous macular traction. The traction is starting to happen, isn't it? Because it started to pull and cause this cystic space. And with this patient, obviously being able to look at them over time, being able to obviously monitor but educate the patient, and this is the biggest thing here. We want to be able to, one, know if there was any changes from the diabetic side of things as you move forward, but also knowing that they've got an adhesion or a traction on this patient. If they've got any flashing lights, any floaters, we want them to come straight back. So actually being able to talk to the patient and educate them and show them has that big impact on how they understand, and we retain our patients and being able to look after them that way. So well done, you're all doing very well and very interactive, which is really good. We have a male now who's 33. And what is the treatment for this? I've just seen come up for that. Now, obviously, it very much is dependent on the visual acuity. So visual acuity has a massive impact on how and what you would do with that patient. Obviously, when you sort of something like that, obviously looking at everything else in relation, checking that nothing else is going on. But typically what you have to think about with a patient with epiretinal membranes, vitreous macular tractions and adhesions is, if they were to be seen, what would they be done? What would happen to them? Because obviously if their vision is still good, the majority of time they would still be sent back to you and looked after in your care. So it very much is about everything else coming into that patient's information, but also about different pathways in different areas as well. So always just be aware to check your local guidelines. And this is really important for this case, actually. So male who's 33, general health, good, asthmatic. I'm sure you're all shouting out, even before I put up the image, I bet you can put this one. General health, good, asthmatic, uses daily preventer inhaler, no allergies, non-smoker, and no familial ocular health history. Now, well done. There we go. Already got it. Reports central vision blurry this morning and doesn't wear any prescription. Now, this is important, isn't it? Because you've all got it before I show you the image, because you've looked at all the information with that patient. So not needing necessarily to have the B scan. The B scan is going to confirm what you were already thinking. And then that helps you then to understand, to educate, to be able to move that forward if you need to. So quite right, you've all started to look at the clinical history and build that into the story of our OCT interpretation journey, which is really what we're doing here. So our profile, if we're looking at our posterior hyaloid layer, all normal, we can see we've got our normal foveal depression. Our intraretina, so from ILM to ELM, is all intact. And remember, go to a point where it's intact and follow with your finger or your mouse, then working out the area that you're looking at. So this is an area of subretinal fluid. Remembering CSR, this is quite a clean CSR. Sometimes we get chronic CSR where you may get sort of more kind of dangly bits that sort of where it's starting to try and stick back together, but it doesn't, so it's repeatable. You can sometimes see that quite clearly. So this is a CSR case though, so well done. So this one is a patient who is 73. They have general health's okay, no regular medication, family ocular health, mother is a high myope, okay, so routine eye test and no complaints. So important with this one, I've shown you this scan, and it kind of, if you're thinking about the first things I talked about, which was scan quality and looking at patients, trying to get what's happening in their normal scan profile, we've taken this image off center. So we've got the patient to move their fixation and we've taken it slightly more peripheral. So here, as we've all put, on the sparkling on the top, we have an epiretinal membrane. Patient's vision's not affected. It's not looking at the central macular area, and the ELM, photoreceptors, RPE, all intact in the sections that we can see. So this is just a normal routine sight test, and this has just been picked out. Patient's probably not even aware of it, but it just means that we've got it on our records to be able to monitor and progress moving forward if need be. This one, we have a 60-year-old female, general health, high blood pressure, medications for that, smoker, 10 a day, family history is brother AMD, overdue tests and no complaints. So with this one, now this image is slightly out of focus on purpose, obviously, and it's also an image that is a single line scan. So I've already said that when you're looking at this, always important that you would scroll through on your pre-screening scan from left to right the whole way along, because especially with this, and you're all guessing quite rightly so what's happening here, we'd want to make sure that the posterior hyaloid layer isn't visual and isn't still attached at any point, because obviously that still has a tendency then to pull. But if the posterior hyaloid layer has come away and this has caused this hole, which as you quite rightly saying is a lamellar hole, this means that this is unlikely to change. Now we would still monitor that patient and we'd still want to use OCT, but because the vision is still good, the likelihood is, obviously, as you know, nothing would be done with this patient. So yes, they've got a lamellar hole, but the posterior hyaloid has gone. There isn't any signs of ERM. So with this is probably how they would stay. And we can use our OCT to monitor that. If they've got a macular hole and it's still got the posterior hyaloid layer attached, it could continue to grow. And there's 4 stages of macular hole. So, you know, we may look at them and we can change that as we go through. So really important just to look at those signs and symptoms. Now, this one, we have a 63-year-old, general health good, meds recently given, non-smoker, no family or ocular health, told at the last eye test they had age-related changes, but has reports episodes of flashing lights and metamorphosia. So vision has changed. So this patient is symptomatic. There's a lot going on because the last time they were told they had age-related changes. So are the age-related changes still visible? Yes, they are. And actually, what else is going on with this patient? So when we're looking here, we're now visualizing our posterior hyaloid layer. The scan is just about able to be looked at, but it's a little bit grainy in places, but that could be because of the pathology as well, so that it was harder to get on the signal. But posterior hyaloid layer is visual. It's still attached, okay, and is still causing some traction. So our profile has changed. We've got these large, very sort of well-defined cystic spaces in the intraretinal section, and we know from the ILM down to our ELM, go to a point where the ELM is intact and follow through, and we can see the ELM changes, but it is still visual here. Okay, so it is still there. Now, we do have an epiretinal membrane, so we can see some sort of sparkling, and the rest of the sections either side seem okay. When we come down to our RPE, we do have these age-related changes, don't we? We've got some quite confluent drusen's, and on our thickness maps, we can see that we've got some retinal thickening. But this patient is symptomatic. They've got episodes of flashing lights and metamorphosia. So with this patient, you are looking at a patient who's got vitreous macular traction, and the age-related changes are obviously just there. But what we have to be aware of is that because the patient's symptomatic, vision has dropped, with someone like this, they may need to go and obviously have a second opinion for an ophthalmologist and be able to then decide whether or not they would actually need treatment. Now, it may be that this pings off and that settles down on its own, but because of everything going on with this patient, you would want to be able to obviously use the OCT to educate them, but also maybe to move forwards. Okay, so we're on the last one now. We have got a patient who attended a cataract assessment and had cataract extraction, reported near vision more difficult, lines appear to have bends over the last 3 months. General health is good, Amsler, right eye is full, left eye there's a scotoma inferior left quadrant and distortion all over the grid. And with this patient, the reported near vision has become more difficult over the last 3 months. Now, again, not just using our B scan, because we can see the areas here of change, and we've got this kind of little suspicious area of highly reflectiveness in our bottom layers here when we're looking at our sub-RPE sections and fluid in this section as well. But looking at our fundus, looking at our thickness maps and our shadowgram, we're actually able to see that this is a case of wet AMD. Now, with some patients, you expect, and I get asked this a lot, that a wet AMD patient would typically be all over the place. You know, they'd have very large, all areas affected. That doesn't always happen. So being able to pull the information in for that patient is really important. Now, when you're looking at a patient and starting to pull the picture together, what's really important is starting to think about, were there any age-related changes before and what's happening with this patient. So that's really important to how we then start to look after them and move forward. This is actually what happened to them afterwards, just to give you a little bit more information on this patient. The VA on the day of the treatment was 612, and actually now it appears dry because they were given some injection, and they can now be observed and reviewed 1 month in a new strategy, which was in this treat and extend clinic of this particular practice. This was actually one of my degree patients that I'm showing you here, but it's just nice to show that you can use the OCT to teach them, to educate, to refer, but then also to show them the effects of their treatments afterwards. Now, thank you. I know I've overrun a little bit, so thank you very much for listening to me this evening. I do hope you found it helpful. We do have a education e-learning system, which you're all very welcome to join as part of your learning and in your interpretation of OCT. There's some webinars and things on here as well that may help you, which is Topcon Healthcare University. And we are running an OCT conference in March next year as well. So you'll be able to find me on LinkedIn if you wanted to find out any more information. But thank you very much for listening, and I will pass you back to David.
Thank you very much, Nicola. A massive thank you. It's been educational and insightful, so I'm sure everybody has enjoyed that. And just very quickly, guys, we do have a couple of minutes just for any questions in the chat, if anybody wants to ask anything in particular.
They were all very interactive, so I was very impressed. So
yes.
It's obviously, especially yes. When we're doing it and it's a lecture and they've just listened to me for an hour. So really do hope that they found it interesting. I would say the biggest tips for me as I've gone through my interpretation journey is really just looking at images. The more you learn, the more you look at them, the more you see them, the more you start to understand that what's normal, and pulling that into that information along with everything clinically. Don't ever forget that. You've got a massive clinical background, so please do use that to help you with your interpretation.
Just one question, I think, on there. How well does OCT work with asteroid hyalosis?
Yeah, okay, so visualizing obviously depends on the OCTs, depending on the signals of the OCTs, and very much being able to visualize obviously the speckles, if you like, within the vitreous, but you can on some patients visualize it. So obviously just being able to see and get a good quality scan if that's physically possible, but you will find images that will show you that on a retinal profile.
Marvelous stuff. Okay, and a couple of people saying one of the best OCT talks that I've been involved with. Thank you very much.
Thank you. Well, I'm very sad as I am. I absolutely love teaching and talking about OCT and interpretation. If it helps you, then I'm happy. I've done a good job. So please always reach out if you need to. Very happy to try and help you.
Fantastic stuff. So last call for any questions, guys. Is there anybody that has anything else to ask? Otherwise, we'll call it there and leave you to enjoy your Thursday evening. Just so everybody knows, the CPD points will be with you within a working week, and we'll send that out to everybody who registered and obviously attended for the hour as described. So that will come directly from us through to you, the email address that you registered under. Someone's asked there if they can get a copy of the slides, Nicola.
Yeah, you can probably have a PDF version.
Okay,
that's fine.
Fantastic. We'll arrange for that to be sent out to you, Sarika. That's fine. That's no problem at all. Okay, great stuff. I think that's us for this evening then. Thank you again, Nicola. Excellent presentation and insight. And yeah, we look forward to working with you next year. And
Fantastic.
thank you for attending, everybody. Have a good evening, and we'll see you all soon.
Thank you. Take care. Goodbye.